Hello, dear students and friends. Today I would talk about vacuum extraction or Ventouse, which is a form of assisted vaginal delivery. We know that in the modern era, assisted vaginal delivery is almost a lost art. However, there are some indications for use of forceps and Ventouse. Ventouse or vacuum extractor is the most commonly used instrument. In my talk, I shall highlight some very important aspects of the use. So ventouse or vacuum extraction as the last minute help. In my talk, I would be covering the following aspects: introduction and incidents, indications and contraindications, the instrumentation, the various prerequisites to be fulfilled, something about failed procedure and what to do, safety criteria, and lastly, decision making. Well, obstetricians do well to leave childbirth to nature, but at times interference is required. History is littered with numerous instruments used to deliver women in obstructed labor. The Chamberlain family invented the modern obstetric forceps nearly 400 years ago. James Simpson introduced the first vacuum extractor in 1840. Then it had its bird modification 30 years ago. And over the last few years, there has been a gradual move from forceps to vacuum extractor. Now let us look at the incidence. It varies from country to country and from one obstetrician to another. In United States, the incidence of assisted vaginal delivery is 3.1%, forceps being 0.5%, and vacuum births 2.6% of vaginal births. However, in United Kingdom, it is between 10 to 15%. Consensus at RCOG conference was to aim to lower the rate to an average of 8.5%, that is between 5 and 15%. Prevalence rates also vary depending on the local practice patterns and the availability of trained clinicians and other necessary resources. In a large prospective study of low and middle income countries, operative vaginal birth rate declined from 1.6% to 0.3%, while the cesarean section rate more than doubled to reach 14.4%. Let us look at the various indications. An operative vaginal delivery should only be attempted when there are specific obstetric indications. These indications can be divided into three major categories. First is prolonged second stage of labor. Second, non-reassuring fetal status like fetal distress. And third, for which it is mainly used, shortening of second stage of labor for maternal benefit. There are no absolute indications as such. According to ACOG Practice Bulletin, scenarios potentially appropriate reasons for operative vaginal birth include maternal exhaustion and inability to push effectively, maternal medical indications like cardiac disease, and a need to avoid pushing in the second stage of labor, prolonged second stage of labor, then suspicion of immediate or potential fetal compromise. However, no indication is absolute, and cesarean birth is also an option in these clinical settings. Now, let us come to the contraindications. Mainly for vacuum extraction, preterm birth is the main contraindication. So, to assist delivery less than 34 weeks due to perceived increased risk of birth injuries in preterm infants. Intracranial hemorrhage occurred more frequently, less than 34 weeks, and prior scalp sampling or multiple attempts at fetal scalp electrode placement are relative contraindications because scalp trauma from these procedures may increase the risk of cephalhematoma or external bleeding from the scalp wound. For any operative vaginal delivery, the contraindications are suspected fetopelvic disproportion, known fetal demyelinization diseases like osteogenesis imperfecta, maternal connective tissue disorder like Ehlers-Danlos syndrome, and fetal bleeding diastasis, which may occur in thrombocytopenia or hemophilia. Coming to the instrumentation, there has to be a vacuum pump, a cup to attach to the fetal scalp, and a handle which attaches the vacuum cup to the cup which is attached to the fetal head. So that this handle is pulled to generate traction. Suction is generated manually or with electrical suction devices. Then we have the newer devices which have everything all in one. The Kiwi Complete Vacuum Delivery System device, the Mighty One piece, and the Mystic 2 vacuum all come with a pump integrated into the handle of the device so that the operator controls the vacuum without the need of an assistant. Then coming to the cups, there could be soft cups or rigid cups. Soft cups are generally bell-shaped, rigid ones are mushroom-shaped. This difference in traction between bell-shaped and mushroom-style cups may be the result of interaction between the cup's edges and the scalp chignon that is formed. Bell-shaped cups tend to draw the chignon into the cup, thereby reducing the available vacuum area and leading to a decrease in cup adhesiveness at edges. So they tend to slip. So this allows leakage of air and detachment. In mushroom-style cups, they draw the chignon into the cup while the edges interlock with the base of chignon, thereby creating a mechanical attachment that seems to compensate for the loss of available vacuum space. Now, where to apply this cup? This cup is applied at the flexion point. Flexion point is a point which is 2 to 3 centimeters above the posterior fontanelle on the sagittal suture. The center of cup should be at the flexion point. However, in occipito-posterior positions, the flexion point is positioned more posteriorly and high in the vagina than the occipito-anterior presentations, and therefore we may need to make certain adjustments. Specifically, the cup needs to be placed much deeper in and posterior into the vagina. This accommodation usually necessitates a vacuum device with a discoid rather than bell-shaped cup and a non-fixed traction cord rather than a firm stem. To meet these needs, special cups have been designed for occipito-posterior presentation. So this is the instrumentation, and especially the handle, the pipe, and the vacuum generator system. If you look at the cups, soft cup, rigid cup for occipito-anterior position, rigid cups for occipito-posterior position, they are of various materials and of various sizes depending on the baby's head size. Now, before applying a vacuum extractor, certain prerequisites need to be fulfilled. The cervix must be fully dilated. It could be 8 centimeters in case of vacuum extraction, while in forceps, it needs to be fully dilated. Membranes should be ruptured. There should be an adequate pelvis, adequate uterine contraction, maternal anesthesia should be satisfactory. Fetal size, presentation, position, and lie must be known. That is, it should be a vertex presentation with the head deeply engaged. Clinician must be experienced, and the option of performing an immediate cesarean delivery should be possible. This is a good mnemonic for understanding vacuum extraction. A, B, C, D, E, F, G, H. First, A, ask for help, address the patient. Always inform her what you are going to do and get an informed verbal consent. Assess anesthesia needs. B stands for bladder empty. C, cervix fully dilated. D, to determine the fetal position, and always think of CPD and think about shoulder dystocia. E for extractor and resuscitation equipment to be ready. F, apply cup at flexion point. G, gentle traction in the proper axis. H, for halt traction when the contraction is over. So with contraction, we need to give the pulse. Halt the procedure if it is not progressing normally. This is a beautiful video in RHL, Reproductive Health Library, on vacuum extraction, which you can go through, which shows the procedure all in one. Now, the most common disadvantage is failure, and an ultrasound is a potential tool which can help us in predicting failure. So in these cases, in the second stage, we can go for an ultrasound scan. Using an ultrasound, we can measure the distance from the presenting part of the fetal head to the maternal perineum and predict vacuum delivery success based on the number. Thereby we can calculate the head to perineum distance, and if it is more than 35 mm in one study and more than 40 mm in another study, which correlated with +2 station of head, these were associated with higher vacuum failures and more difficult extractions. A combination of ultrasound measured angle of progression with fetal head circumference also was used to predict complicated versus uncomplicated operative vaginal deliveries. In this model, an angle of progression with pushing of less than 115 degree and a fetal head circumference greater than 345 mm predicted 87% of complicated ovarian vaginal operative vaginal deliveries. So in these cases, if you go for an ultrasound before thinking of applying a vacuum, it would be very, very helpful. Now about the failed procedure. Failure is said to occur if there is no evidence of progressive descent with moderate traction during each pull of a correctly applied instrument by an experienced operator. If fetus is undelivered after 3 pulls with no descent or after 30 minutes. So you can wait for 30 minutes and after that, you need to abandon the procedure. The cup lifts off twice at proper direction of pull with maximum negative pressure. So if the cup pops off, now in these situations, we can consider a cesarean section and an experienced operator can do a symphysiotomy as well. Management after a failed procedure. Prompt cesarean delivery is often advised after an unsuccessful attempt. However, failure of an attempted vacuum-assisted delivery increases the likelihood of neonatal morbidity. So after the vacuum fails, we can think of applying a forceps if the operator is well experienced. And this is known as use of sequential instruments. The subsequent use of sequential forceps in this setting has been associated with increased risk of neonatal intracranial hemorrhage and is rarely indicated. The use of sequential instruments is associated with increased risk of trauma to the infant. In all such cases, we must inform the neonatologist when this occurs to ensure appropriate care of the baby. However, the operator needs to balance the risk of cesarean birth in second stage following a failed vacuum extraction with the risk of forceps birth following a failed vacuum extraction. So risk versus benefit ratio should be considered before deciding the use of forceps. The increase of obstetric anal sphincter injuries has been seen following sequential use of these instruments. Now, the advantages of vacuum versus forceps. It is easy to apply, less force on fetal head, does not affect diameter of fetal head, can be used for rotation and occipito-posterior positions, requires less maternal anesthesia, less invasive, it takes up less room inside the pelvis, less pain to the mother at delivery and 24 hours later, and serious maternal trauma is less like sphincter damage. But if we look at the disadvantages, mainly it affects the fetal head. Failure is more as it does not pull with much force, cannot be applied on a premature infant, but fetal trauma in the form of scalp edema, that is chignon, which is always there in every case, but then subsides. Then serious injuries could be in the form of a cephal hematoma, bleeding from scalp lacerations, retinal hemorrhages, subclial hematoma, and intraventricular hemorrhage. Now, after any assisted vaginal delivery, this pro forma must be filled. And you should include everything, including the operator, the supervisor, the indication of birth, classification, whether you've used outlet or low vacuum or forceps, classification of the CTG, the degree of rotation, examination findings, about the prerequisites, then the procedure, regarding expected blood loss, about the baby, ABGAR of the baby, cord blood pH, post-birth care, etc. So it is a must to fill this pro forma. Now, the most important thing when to consider before applying a forceps is whether to do it or not, whether to consider a cesarean birth or to give a trial for vacuum. The decision making is the most difficult thing, and this chart would help us in identifying whether we should do it or not. First and most important thing is we must select the optimal place for birth. We can continue in labor room if the head is low at the outlet, there is no rotation or it rotates easily and there are no features of CPT. But we must consider trial in theater if head is 1/5 palpable, head is in mid pelvis, rotation is required and there is suspicion of CPD, yet you want to try. Then the instrument, it could be a forceps or vacuum. Selection of instrument you're most competent at using. So that instrument should be used. Select instrument least likely to fail, avoiding sequential use of instruments. Avoid vacuum if the baby is preterm, even if less than 36 weeks. Correct application of instrument. If unable to achieve correct application, reassess engagement position, station, and asynclitism. Seek second opinion. An experienced operator should reassess, consider reapplication, and discontinue if not achieved correct application with the above measures. Now, in some cases, rotation is required. If indicated, attempt rotation. But if unable to achieve rotation easily, a senior obstetrician should be called to check correct application and correct rotation technique to be applied. Discontinue the procedure if rotation is not achieved. Birth in direct occipital posterior position may occur with vacuum or at low station forceps. Now, at times, traction may not be possible. Attempt traction. If progressive descent is not observed with appropriate traction, again, check whether the instrument is applied correctly, reassess for features of CPD, seek second opinion. An experienced operator may revise the approach, may change the instrument or alter the direction of traction, and discontinue the procedure if descent is not achieved by the above two measures. Now, if you've applied it twice and there are pop-offs, the instrument slips off, then you must abandon the procedure. Now, reassess after 3 pulls. You've tried 3 pulls. Consider discontinuing the procedure if in vacuum-assisted birth, the head is not on the pelvic floor with maximum 3 gentle pulls. If forceps birth and the head is not crowning with birth imminent. Failed attempt at operative vaginal birth. Consider the consequences of failed attempt. Consider forceps followed by vacuum only with vertex at low station. Increased risk of trauma to the fetus and obstetric anal sphincter injury with sequential instrument use should be kept in mind. And we must know that there is increased morbidity for the mother with cesarean in second stage and increased risk of fetal head impaction at cesarean birth. So take your decision wisely whether to go for a cesarean or to go for a vacuum delivery. In all such cases, inform the neonatologist of increased risk of neonatal morbidity. And after you've applied it and it has been successful, complete the proforma. Debrief the mother. You need to tell the mother what had happened, why did you apply the instrument, and debrief the partner and the family. So my take-home message is operative vaginal delivery complements cesarean delivery and cannot replace it. Vacuum extraction, well applied, can reduce a cesarean section rates. It can reduce maternal and perinatal morbidity as well. It is a boon in cardiac disease, a blessing in high up head in second of twins. So vacuum or Ventouse is a noble and beneficial instrument, rescuing more lives and cutting short more pains than any other instrument in the armamentarium. So thank you. Question and answers are allowed. You can write down the questions and I would be happy to answer them. And do subscribe to my channel. Thank you.